This is Neander Tabingo, Frontier Nursing University, NP 702, Fall 2016. This is my SOAP note presentation titled Bloody Nose. Subjective data. Chief complaint. My nose has been bleeding periodically on the left side and it's bright red. HPI. This 73-year-old white female presents in clinic with complaints of spontaneous moderate brisk, bright red, painless nosebleed for the last half hour. Has been experiencing small amounts of painless left-sided nosebleed mostly in the mornings and lasting a few minutes each time, once or twice a week for the past 4 weeks. Resolved spontaneously after pinching the nostrils. Denies left nasal blockage, headaches, loose teeth, or deep ear pain. Denies picking a nose or forceful nose blowing. Currently taking Plavix and ASA for stroke and MI prophylaxis. Denies history of bleeding disorders. Past medical history, MI and CVA 7 months ago, no residual weakness, denies head or neck tumors, bleeding disorders, hemophilia or liver disease. Active medical problems, hypertension. Family history, mother alive, dementia, CVA, father deceased, lung cancer, ETOH abuse, sibling, one brother alive, hypertension, COPD, maternal grandmother deceased, CVA, breast cancer, maternal grandfather deceased, diabetes, heart attack, paternal grandmother and grandfather deceased, unknown history. Surgical history, hysterectomy in 1971, tonsillectomy at 15 years of age, no previous nasal or sinus surgery. Social history, drinks 1/2 glass of wine with dinner, denies tobacco or illicit drugs, lives with husband and 2 dogs. Allergies, no known allergies. Medications, Plavix 75 milligrams PO daily, 7 months now. ASA 81 milligrams PO daily times 7 months now. Metoprolol 25 milligrams PO BID, taking for 1 year now. Immunizations, flu, October 2016, Pneumovax 2012. Review of systems, HENT, denies head trauma, headaches, facial pain, visual problems, sinus pain, nasal insertion of foreign bodies, nasal congestion, loss of smell, feeling of blood dripping down throat. Integumentary, denies easy bruising. Cardiovascular, denies chest pain or pressure, palpitations, difficulty of dyspnea and insertion, orthopnea, dizziness, fainting, lower extremities edema. Respiratory, denies asthma, shortness of breath, wheezing, hemoptysis, cough, lung disease, or history of bronchitis or pneumonia. Review of systems continued. GI, denies nausea, hematemesis, abdominal pain, diarrhea, constipation, indigestion, melena, rectal bleeding, hepatitis or other liver disease. Genitourinary, denies hematuria, vaginal bleeding or problems. Neuro, denies neurological deficits, seizures, ataxia, headaches, dizziness or forgetfulness. Hematology oncology, denies cancer or other blood disorders. Objective data. General appearance, vital signs, temperature 97.2, pulse 89, respirations 22, blood pressure 140/65, O2 sat 97% room air. Height 167 centimeters, weight 60 kilograms. Constitutional, well-developed, well-nourished, elderly female, appears stated age and mild distress, alert but slightly agitated, talks in sentences. Physical exam. Skin, warm, pink, dry, no rashes, pallor, purpura, petechia, or telangiectasias. HENT, head, no facial swelling or deformity. Eyes, no conjunctival hemorrhage, ductum, no masses, no septal deviation, limited exam due to bleeding. Right nose pink, intact nasal mucosa, mouth, mucous membranes, gums, tongue, moist, pink without lesions. Heart, regular rate and rhythm, S1, S2 clear, distinct, no murmurs, jugular venous distension, edema, and there are strong peripheral pulses. Lungs, clear lung sounds in all fields, full expansion, no chest wall tenderness. Lymphatics, no cervical nodes enlargement. Diagnosis, epistaxis, anterior bleed. Definition, epistaxis is a Latin term derived from the Greek words epi, above, and stasin, to drip. It is one of the most common ENT emergencies to present to primary care practitioners, Yao 2015. GARG 2015 defines epistaxis as bleeding from the nostril, nasal cavity, or nasopharynx. It can range from recurrent mild bleed to severe life-threatening emergency, Sarhan and Al-Gamal 2015. Etiology. Local causes are trauma, facial trauma, or local irritation from picking, forceful nose blowing, neoplasia, upper respiratory infection, chronic sinusitis, exposure to irritants, cocaine abuse, allergies, angiomas, nasal steroid sprays, and septal abnormalities. Systemic causes are granulomatous diseases like Wegener's and sarcoidosis, hereditary hemorrhagic telangiectasia, infection, bleeding diathesis, malignant hypertension. Environmental causes are dry indoor environment and lack of humidification, winter months with changes in temperature and humidity, and circadian rhythm where epistaxis are common in the morning and late afternoon. Yao 2015, Gurol and Molly 2014, GARG 2015. Medications causes include NSAIDs, warfarins, clopidogrel, and factor X inhibitor or factor 10 inhibitors. Yao 2015. Idiopathic is unknown cause. Pathophysiology. The nasal cavity receives blood from the internal and external carotid systems and is therefore very vascular, GARG 2015. Disruption of the nasal mucosa by trauma, ulceration, bleeding disorders, inflammation, and neoplasms result in epistaxis, Gurol and Molly 2014. Risk factors are related to etiology and include nose picking, coagulopathy, acute or chronic sinus infections, uncontrolled hypertension, liver disease, alcohol abuse, blunt nose trauma, cocaine use, dry and cold climate, septal deformities, granulomatous disease like Wegener's and sarcoidosis, and long-term use of anticoagulants, Follier 2016. Prevalence, about 60% of the population will be affected by epistaxis at some point, GARG 2015. It is the second most common cause at 33% of all emergency ENT admissions after sore throat, Barnes, Spielman, and White 2016, Dynamed Plus 2014. It is common in children below or at 10 years old and adults above 50 years old, Dynamed Plus 2014. 90% of nosebleeds occur anteriorly, GARG 2015. Death from epistaxis is rare. In 2005, there were 7 deaths related to epistaxis in the US, all aged 75 and older, Barnes, Spielman, and White 2016. Common symptoms. Anterior epistaxis is usually unilateral, continuous, moderate bleeding from a group of blood vessels in the anterior septum called the Kieselbeck plexus. Most are venous, but arterial source becomes common in advancing age due to mucosal and vascular atrophy. It is the most common site for those taking antiplatelet agents. Anterior bleeds account for 90% of epistaxis incidents, Gurol and Molly, 2014. Posterior epistaxis is intermittent, brisk, arterial bleeding flowing posteriorly into the pharynx, common in the elderly and those with severe facial trauma, Gurol and Molly, 2014. Hemoptysis, nausea, vomiting from swallowing blood, hematemesis, melanat from posterior bleed or anterior bleed with high blood flow, Yao 2015, Hollier 2016, and Dynamed Plus 2014. Differential diagnosis. Because epistaxis is a symptom, Hollier 2016, I have decided to do differential diagnosis based on etiology. First is the presence of long-term use of antithrombotics and antiplatelets. The bleeding tendency associated with antiplatelets or thrombotics is most likely due to the locus Kieselbeck in the left nasal septum as the apparent source of bleeding according to the physical exam. The presence of a tumor that could be anterior is also considered due to the unilateral nature of the bleeding. And because of poor visualization due to bleeding, this cannot be ruled out. Third, idiopathic epistaxis, because of the apparent source of the bleeding in the left nasal septum. Essential Evidence Plus 2014. This is authored by Blomgren, 2014. I did not consider ruptured carotid artery, aneurysm, or traumatic carotid cavernous fistula, as these are severe forms of bleeding that will not probably present in primary care. Immediate treatment. Adult epistaxis management, foremost, is to protect airway and assess cardiovascular status. Advise patient to sit and lean forward so blood does not run down the posterior pharynx, and hold Ems's basin to catch any bleeding. Have patient pinch nostrils, not the bony bridge of the nose, to apply direct pressure to septal area for 10 to 15 minutes. Anterior packing with Merocel or procoagulant dressing such as calcium sodium alginate for a patient on antiplatelet therapy is helpful and useful. Dynamid Plus 2014, Barnes, Spielman, and White 2016. Medications. In the clinic, oxymetazoline is the first-line treatment. Silver nitrate applicators may be used once site is identified. An alternative for patients on antiplatelets, like our patient, would be the use of procoagulant dressing such as calcium sodium alginate. Dynamid Plus 2014. Diagnostic tests. Gorol and Molly 2014 state that lab studies are ordered in the basis of findings from the history and physical exam. Usually, no lab test will be ordered for epistaxis that is not severe, but a history of Plavix and ASA will warrant checking the hemoglobin and platelet counts. Collier 2016. Medication side effects. Oxymetazoline has minor side effects of burning, dryness, stinging inside the nose, sneezing, rhinorrhea. Have the patient report immediately to prescriber if there is angina, tachycardia, passing out, severe headache, or severe nasal irritation. Educate the patient about signs of a significant reaction like wheezing, chest tightness, fever, itching, bad cough, blue skin color, seizures, or swelling of face, lips, tongue, or throat. Drugs.com for Professionals 2016. Care should be taken when using silver nitrate applicators for patients with history of nasal surgery or those taking antiplatelet agents. There is a risk of further bleeding and septal perforation. Gorol and Molly, 2014. Patient education. Instruct to avoid trauma to mucosa, avoid picking, excessive rubbing, excessive and forceful blowing. Keep septum well coated with vitamin A and D ointment, petrolatum base zinc oxide or OTC bacitracin ointment until site is healed. Teach home remedy for minor recurrence of bleeding by first spraying afrinasal spray to bleeding mare, then packing the site with cotton pledget soaked in afrinasal spray and apply to the area for 10 minutes. Consider use of OTC nasal Cs, a calcium alginate-based packing that can be used at home. Explain importance of humidifying the home, partially opening a few windows, placing water in containers near radiators or stoves, obtaining a humidifier. Consider stool softener to prevent bearing down and increase risk of nosebleed. Gorol and Molly, 2014. Consult or refer. If there's a possibility of a tumor, consult to refer to an ENT. Recurrent bleeding despite treatment, hematology, or hospitalization if severe bleeding. Bleeding that stopped by tamponade could be posterior bleeding and needs to be sent to hospital right away. Dynamid Plus 2014, Gorol and Molly 2014, Yao 2015. Follow-up. Call the clinic if home treatment fails. Follow up within 24 to 48 hours after nasal packing for anterior epistaxis. Earlier follow-up is recommended if there's bleeding, fever, drainage, or increased pain. Consider leaving pack in for 48 hours if the patient is on anticoagulation medication such as warfarin, high cardiac risk, or hemoglobin less than 9. Irrigate packing with 5 to 10 ml saline and wait 5 to 10 minutes to prevent material from sticking to mucosa before removing the pack. If bleeding not resolved, suspect posterior epistaxis. Remove all packing for posterior epistaxis within 48 to 72 hours to prevent tissue necrosis and infection. Advise patient to avoid picking or blowing the nose for 1 week and bending over or straining. Dynamid Plus 2014. Health promotion: avoid alcohol. Patients with epistaxis were likely to have consumed alcohol within 24 hours of presenting to the clinic or the hospital. Alcohol and clopidogrel don't go together. Manage hypertension to prevent malignant hypertension, which may predispose to epistaxis, although there is a weak evidence in the relationship between hypertension and epistaxis. Prevent upper respiratory tract infection. Lubricate nares often, humidify at night and at winter time, and stop smoking. It dries the nasal passages. Yao, 2015, Hollier, 2016. Pharmacological treatment guidelines. The treatment guideline for epistaxis from the American Academy of Physicians is 11 years old, hence was not referenced here. Afrin or oxymetazoline, 0.05% nasal sprays first line. Spray twice into each nostril. Have the patient pinch nostrils tightly for 10 to 15 minutes after. Oxymetazoline spray as sole therapy is reported to resolve epistaxis in 65% of patients in one study. Gelatin thrombin hemostatic matrix sealant or FlowSeal was reported to resolve bleeding in most patients with epistaxis and appears more effective than nasal packing. Tranexamic acid, soaked pledget, may resolve bleeding and reduce risk for rebleed more effectively than anterior packing with epinephrine and lidocaine, soaked pledget in patients with idiopathic anterior epistaxis. Procoagulant therapy, like calcium sodium alginate nasal packing for patients in anticoagulation or antiplatelet therapy, may be more effective and preferred over local treatments such as cautery. Dynamed Plus, 2014. Silver nitrate, 95% applicator stick should be used with caution in the elderly or those with epistaxis resulting from antiplatelet therapy. These patients have friable blood vessels. Other modalities, electrocautery or with silver nitrate is recommended next to topical vasoconstriction with oxymetazoline. Silver nitrate may be applied in the clinic. Use with caution in the elderly and those on antiplatelet therapy. Nasal packing is the next step after cautery. You may pack anteriorly in the clinic, but posterior packing is best done by the ENT or in the ER. Barnes, Spielman, and White, 2016. Diet. Hot foods can trigger nosebleed. Yao, 2015. Activity. Strenuous activity, bending, straining, nose blowing, all put the patient at risk for recurring nosebleed. Dynamed Plus, 2014. Yao, 2015. Here is my prescription for Afrin nasal spray and for bacitracin ointment. And here's my prescription for the orders for the CBC. And here are my references. Thank you for watching.